Georgina, are you looking forward to seeing results of PD-1 inhibitors? Will that be the next best adjuvant therapy? Will that be better than ipilimumab?
I can't answer the question as to whether it will be better than ipilimumab, but I am very excited to see the results for sure. We know that anti-PD-1 therapies work better than ipilimumab in stage 4, but we can't necessarily say the same thing will happen in stage 3. The way that anti-PD-1 therapies work is different to anti-CTLA-4. Anti-CTLA-4 works at an earlier stage in the immune cycle, and perhaps the anti-PD-1 antibodies require a tumour bulk to have their greatest activity. I don't know, but what I'm just suggesting is that we should wait for the data. I'm hopeful, and I'm pretty happy that we may see better results, but we just don't know.
Okay, so Jason, what about ipi-nivo? Is there a place for concurrent combination therapy as adjuvant therapy?
Well, so that's an open question that will be answered by an ongoing trial. I have to say that from my perspective, that's a question mark as to whether or not there really is a role there. I think I base that off of what we've seen in the metastatic setting, where there is an improvement in survival, but that is quite modest. So that if you then extrapolate that backwards, does the amount of toxicity in the adjuvant setting, as we're talking about in patients who don't have cancer, can that really be justified based on what we now know in the metastatic setting of some, a statistically significant but clinically questionable amount of difference in terms of overall survival?
Yeah, which relates to a question that came up at the melanoma session. Someone just made, it was a comment, I forget who made the comment, but you have to have a different tolerance for toxicity in the adjuvant mode when half of your patients may be cured just sitting there in your office. And versus the metastatic mode, whereas if you don't treat them, they're going to die. So I would agree it's a different scenario.
There's one more point to make on that, though, is that in the metastatic setting, we did not see any deaths in 067 on the combination of ipilimumab and nivolumab. And that's presumably because we're much more experienced in dealing with immunotherapy toxicities, whereas the very high rate of deaths with 10 milligrams of ipilimumab may be an experience thing in that these trials were conducted earlier in the piece.
Yes, I would agree. So we also heard about the adjuvant bevacizumab trial. Mike, any reason why we should be thinking about angiogenesis inhibitors as adjuvant therapy? I was a little surprised to hear this trial, but...
Yeah, no, I don't think so. I mean, so, what happened was we got sort of the final report with at least 5 years of follow-up on a randomized study of adjuvant bevacizumab versus just surveillance. And the results showed that there was a statistically significant improvement in relapse-free survival, but not in distant metastasis-free survival or overall survival. And so I don't think at this time, particularly with the data that we have with ipilimumab, that there's really a role for that at this point.
Okay, and so last point in the sort of thinking about local regional therapy. Robert, do you routinely do any type of neoadjuvant therapy, whether it be immuno or targeted in patients to render them resectable?
So we do. I think that we do this usually on clinical trials, if at all possible. And we have a number of clinical trials that we have conducted actually internationally, one of them being with oncolytic virus such as telimagin leherparepvec, also known as TVEC. And we had a randomized study in which patients received surgery up front for resectable disease, and versus having 3 months of TVEC and then having surgery. And the primary endpoint for this is recurrence-free survival. So that study has closed, and we should have data coming out within the next year and a half, we hope. There are also other neoadjuvant studies that have been performed, both with immunotherapies, checkpoint inhibitors, including the PD-1 inhibitors, and also with BRAF-MEK combinations done both in Australia as well as in the United States. And I think that those studies have also shown us that we can use neoadjuvant therapies to decrease the tumor burden prior to surgical resection, which especially in patients that have borderline resectable tumors can be beneficial. In addition, we also hope with these that we will also decrease the risk of recurrence of the tumor once we've used this to try to activate the immune system prior to surgical resection. Now, whether that will hold true in larger studies, we have to see, but that's something that's being investigated at the moment. In some patients, Jeff, we do have patients, especially with BRAF mutations, V600E and V600K mutations. If they have large bulky disease, we often use that, not necessarily on a trial perspective, but we try to use that to decrease the tumor burden before we do the surgical resection. And I think that is something that can be quite beneficial in these patients, because these are patients that are, I would say, marginally or unresectable, but we can potentially surgically resect them after.
Well, you mentioned BRAF testing. That's kind of a nice segue into thinking about who should we be genetically profiling.